Yue Zhao. I'm from St. John University. First of all, I would like to thank the organization committee of the conference for the invitation and giving me the opportunity to meet everyone here discussing the issue on the generic substitution in China. Today my topic is knowledge, attitudes, and practice towards generic substitution, a cross-sectional survey among endocrinology in China. China has the largest diabetes epidemic in the world. Among the Chinese adult population, the estimated standard prevalence of the total diagnosed and undiagnosed diabetes was 10.9%. On the other hand, the total healthcare expenditure, including the diabetes and its complications in China, reached 51 billion in 2015. As we know that the generic competition can reduce the price level, based on our previous study, the results show that the generic antibiotic cost no more than 40% of the brand medicines on average. So the generic substitution as one type of indirect pharmaceutical pricing strategy, the purpose of the policy is to restrain the growth of pharmaceutical expenditure and to improve the patient access to medicine. The generic substitution has been applied worldwide. However, the Chinese government issued quality and efficacy consistent assessment in 2016. So to some extent, the generic substitution in China is a new thing. As we know that the stakeholders' knowledge, attitude, and practice are important when a country introduces a policy. So the patients, physicians, and the pharmacists KAP towards generic substitution has been studied internationally. However, there is no peer-reviewed study access to the KAP towards physicians in China yet. So our project is to investigate the knowledge and attitude and to avoid the factors associated with prescribing behavior among the endocrinology in China. We conducted a national cross-sectional study. Endocrinologists, physicians who worked in tertiary medical institutions and published papers from 2012 to 2016 in the China National Knowledge Infrastructure database were included in our study. We collected participants' email address from the CUKI database. Email invitations were sent to physicians with a link to request their participation in the survey. To encourage survey communication, 3 reminders were sent on May 17, June 1, and June 15. The survey launched on May 10, 2016 and concluded on July 10, 2016. The questionnaire contains 4 parts with 12 6-closed questions. Part 1 includes the participants' demographic characteristics. Part 2 includes the participants' knowledge about the generics. This section was assessed using a 3-point scale. Part 3 and Part 4 was to evaluate the attitude and the practice towards the generic drugs use by a 5-point Likert scale. Frequency and the median were used to describe the variables distribution. KW test and chi-square test were used to analyze the difference. As the frequency of prescribing generics was used as a dependent variable, so all the logistical regression was used to explore the factors associated with the prescribing behavior. Table 1 gives us the characteristics among the participants. We can see that finally 191 physicians were included in our analysis, and the response rate was 17%. Over half of them are female and with high senior degree. And over 60% are under 40 years and with over 10 years work experience. Nearly 60% respondents gain a knowledge score of 3 or above, and only 5 respondents gain a score of 0. Table 2 gives us the participants' attitudes towards the generics. We can see that over 60% agree or strongly agree that the originator's drug have a better quality than that of the generics. Nearly 40% hold the neutral stand. They think that the generic drugs have more adverse reaction. But nearly over 60% disagree or strongly disagree that the generic drugs will need effective treatment or other serious consequences. But only 25% the physicians hold that the originator medicine can be substituted by the generics. Over 60% the participants hold that they need the standard guideline or more information to conduct them how to use the generics. Table 3 gives us the practice. Physicians show that over 60 of the physicians show that they would like to prescribe the originators. This result is consistent with their attitude results. Over 60% physicians show that the patient's opinion, patient's condition, and the patient's cost and their own medication experience. They will consider these factors. Most of them said that the medication representative and advertisement won't or seldom affect the prescribing behavior. The other logistic regression results show that the age, attitude of the quality, concern of the patient's cost, and the physician's self-medication experience other factors associated would affect the prescribing behavior. The following is discussion. In terms of the knowledge, the findings of the study were in line to those of the other published studies in India. As we know, the generic drugs are very common in India. The survey results reveal that the correct knowledge, generic knowledge has not translated into positive attitude for the Chinese physicians. The doubts of the physicians regarding the quality and the safety of the generic drugs given in our study was consistent with those reviewed by the other studies conducted on the physicians. Our results indicate that the physicians in China preferred prescribing originator medicines. Several other studies also found the physicians didn't usually prescribe generics in their clinical practice. However, in some countries, the situation of generic prescribing was encouraged. There are some limitations of the study. Finally, I will highlight 2 conclusions. Physicians had a good amount of knowledge about the generic drugs. However, this was not reflected in their attitude and practice in China. The other is pharmacist's age, concern of the generic quality, physician's own medical experience, and patient's cost were important factors influence the physician's prescribing behavior. Actually, this study is a pilot study, so I hope experts and everyone can give me some comments and questions. Thank you.
Thanks very much for the presentation. My name is Laura from Monash University. It looks like there's a little bit of improvement that can be done in this field in substitution. My first question is, what are your plans for follow-on work from this? And my second question is that you survey prescribers in China. Can pharmacists substitute drugs as well as the prescribers?
Okay, thank you for your questions. The first one, the following work in the future, I think, based on this pilot study, I will improve the questionnaire and improve the survey process, and I will repeat the survey about on the KP toward the physicians firstly. And the second question is about the pharmacist. I think the situation in China is different from especially other countries, especially the Western country. As pharmacists in our country is not the most important. They can't play an important role in China yet now. So actually, the physician as the first survey participant. Yeah. So in the future, I will still focus on the physicians survey. Thank you.
Thank you. Other question? Other question? Stella, please.
Hi, Stella Packman from IQVIA. It struck me that there might be a slight mismatch between the impression physicians said that they were worried about the quality and of the products, of the generics. Yet they said in the other part of the questionnaire, I mean, I could have got this wrong, that they didn't think they'd be any less efficacious or that they would have more ADRs. That seems to be a bit of a mismatch. Do you have any comment? I may have misinterpreted your slides.
Maybe we can put the slide back, Stella. What Stella is saying, there seemed to be a mismatch between some of the responses on the questionnaire. Which slide are you referring to? If we go forward. No?
I think there was one there that they said that the originators of better quality.
Yeah,
The first one.
quality.
And then the next two questions, they're saying they're neutral on whether there be more adverse reactions or ineffective trial. They disagree that they would be less effective.
Yes, so there was a little bit of inconsistency, I think, between the responses.
Between 5 and 6
Yes.
Right. The first question is about the generic quality because before in the last decades, the China they didn't require the generic quality is consistent with the originator, so the physicians think that the quality is not good. The second question about the adverse reactions, I think this is maybe based on their experience and along the history, our drug quality improved. So maybe the physicians keep neutral about the adverse reactions.
Thank you.
Thank you.
Other questions? Okay, I will ask a question. I was interested in the survey methodology you used in terms of how you identify your targets through the publications, and I was wondering if you thought about other specialist societies, for example, where you could get the contact details of the endocrinologist that you wanted to target. The response rate was relatively low, and I was just thinking in future surveys you may want to try and increase that.
I think it's a good question. As we choose the physicians from the CKI, we use they have to publish the papers, and we choose them. They have to from 3 medication institution, and always they always face the trade-off between the generics and the originators. And the other is the response rate. I think it's very low. Yeah, but I think this is the kind of study, and next I will improve the process to increase the response rate.
And how might you do that? Any ideas?
Yeah, I think this is an email online survey, so the response rate also very low. But I think maybe next time in this study we didn't require them they agree to participate in this survey. So we send a lot of email. But the next time I will change in this process.
Okay.
morning, everyone. My talk today is about treatment initiation for type 2 diabetes in Australia and are the guidelines being followed. I'd like to thank my supervisors for their assistance in preparing this. So type 2 diabetes is one of the most significant pandemics of the 21st century and probably one of the most severe pandemics in human history too. Last year alone, in Australia, the estimated number of people with type 2 diabetes was well over 1.1 million, with an incidence of over 100,000 new diagnoses per year, the vast majority of these being type 2 diabetes. So, in order to treat this disease, antihypoglycemics are necessary to prevent complications and to reduce morbidity and mortality. The first-line treatment in Australia and across much of the world is metformin monotherapy. This therapy is cost-effective, doesn't require injection, does not cause weight gain or hypoglycemia, and it also has benefits to cardiovascular mortality, mild adverse effects. However, it is contraindicated where renal function is less than 30 mils per minute. The first-line treatments in Australia are outlined here, with the ones in the border being subsidised by our pharmaceutical benefits scheme. Metformin being shaded is the most commonly used first-line therapy. However, Australian guidelines do not address the issue of initial combination therapy at the point of diagnosis, whereas some international guidelines do suggest the use of combination therapy where HbA1c, glycated hemoglobin, exceeds a certain threshold. The paradigm currently in Australia is that one medicine is prescribed and then 3 months observation waiting by a prescriber, and then subsequent medication should be prescribed. So the rationale of this study was that we considered it was important to understand the factors which inform initial prescribing in type 2 diabetes, and also the extent to which the guidelines are currently adhered to is unknown, so these were considered worthy of investigation, and therefore we wanted to determine the patterns and predictors of different types of treatment initiation. So our data set has been discussed at length by others, but just to summarise, it is a claims-based data set from the Australian government. It contains information about the item name, strength, dispensed quantity, date, and so forth. The year of death, birth, and gender are also included. So the strength of this data set is that it actually does contain under co-payment dispensing information. This was brought in Australia in July 2013. So even medicines which cost less than the specified threshold subsidised by the government are still included. A limitation, however, is that it doesn't contain any clinical information, particularly HbA1c or BGLs. And it's unknown whether people actually took the medication. And also, you don't know anything about privately prescribed medications. So, I mentioned that. The way we classified people was into 3 categories. So, there were people who initially prescribed metformin monotherapy, non-metformin monotherapy, and combination therapy, being either individual products with more than one drug within them or separate products with more than one drug within them. And this was done through the use of anatomical therapeutic chemical classification codes. And people using insulin initially were excluded in order to attempt to remove people with type 1 diabetes. Multinomial logistic regression was used, and odds ratios and 95% confidence intervals were calculated, with relevant comorbidities, which I'll discuss in a minute, being investigated. A validated tool, the RX risk tool, was used in order to identify the number and types of comorbidities individuals were associated with. We also looked at treatment intensification within the first 3 months. So if people started out with metformin monotherapy and moved to combination therapy within 3 months, how did that look as a proportion as a whole? For the sake of brevity, I won't go through this table in detail, but suffice it to say, those who initiate on non-metformin monotherapy are generally considerably older than the whole and have considerably more comorbidities. So in terms of the results, metformin monotherapy did constitute the largest group at about 88%, which is indicative that Australian guidelines are being well adhered to by prescribers, and roughly about 5% of that cohort intensified within 3 months. Roughly 5% of people initiated on non-metformin monotherapy, the vast majority of these being sulfonylureas, and approximately 7% of people initiated a combination therapy, the vast majority of which was 2 therapies. In terms of predictors, with increasing age came increasing odds of non-metformin monotherapy, and also in a less sort of linear fashion, there were also generally increased odds of combination therapy with increasing age. Females were less likely than males to initiate a non-metformin monotherapy or combination therapy, which I'll discuss in a minute. And an increased number of comorbidities was associated with increased odds of being on non-metformin monotherapy. However, the reverse was true. Increased number of comorbidities was associated with decreased odds of being on combination therapy initially. There were also specific comorbidities which had associations with the therapies, but maybe for the sake of time, I won't have time to go through that in detail. So for discussion, initiation of combination therapy was associated with male sex. This was considered to be possibly because males, at least in Australia, are older when they first seek medical attention and when they're first treated for type 2 diabetes, and thus may have had a higher baseline glycated hemoglobin level. Also, with increasing age may come less controlled HbA1c levels, and also with increasing age may come age-related renal impairment, which may be a consideration for prescribers who do not want to provide metformin for someone with compromised renal function. People with a lower number of comorbidities were also associated with combination therapy, which could reflect prescribers' concerns about not overburdening people with too many medications. Heart failure and end-stage renal disease were also associated with combination therapy. So initiation on non-metformin monotherapy was a similar story in that older males had higher odds of this therapy. And here, though, people with a higher number of comorbidities were associated with being in this group. So this is probably, again, related to having more comorbidities probably means that you're a bit more unwell, which probably means that there's higher odds of having age-related renal impairment or some kind of other renal disease. People with steroid-responsive autoimmune diseases, this may affect kidney function as well. Certain types of immune diseases definitely do compromise renal function or impair the kidney's function in some way. And end-stage renal disease, obviously, prescribers are adhering to that guideline recommendation of avoiding metformin in impaired renal function. So conclusions are that treatment initiation in Australia is largely consistent with clinical practice guidelines. Prescribers are definitely cognizant of the warnings about use of metformin in renal impairment. Combination therapy is more common in older people, in older males with comorbidities, and non-metformin monotherapy initiation is actually more common in older males with increasing numbers of comorbidities. Australian guidelines could develop specific advice regarding the initiation of combination therapy, but in order to do this, we actually need to conduct studies to show if there's any real point to doing this, or if it is superior to the current paradigm of staged intensification. Thank you.
Thank you for this presentation. I am wondering about how you got to an older age male with fewer comorbidities being more likely to receive combination therapy. Did you look at these individually, or did you account for being male and then in age?
We looked at the individual adjusted odds as age, So we actually looked at the subgroups of age, and although I didn't show it in this presentation, it was very clear that males were very much older than females at the point of initiation. So that definitely was backed up by data. The fewer comorbidities was a little bit perplexing as well, but we considered that that was probably associated with if someone has a lot of comorbidities, a prescriber probably wouldn't want to overburden them with more combination therapy. And what was the other part of the question?
So these are all adjusted for one another?
All adjusted on ratios, yeah.
Thank you.
Sorry.
A very good morning, everyone. Today I'm here to present one of our research work, that is impact of clinical pharmacist-led post-hospitalization care on clinical as well as humanistic outcomes among patients with acute coronary syndrome. It was a randomized controlled study. I declare no conflicts of interest about this presentation. So as we know that acute coronary syndrome is a spectrum of conditions which is compatible with acute myocardial ischemia or the infarction, and that are usually due to an abrupt reduction in the coronary blood flow. Coming to the epidemiology of these cardiovascular diseases, as we know that cardiovascular diseases are the leading cause of death globally, and if you see the statistics, there were 17.9 million people died from these cardiovascular diseases in 2016, and that comprises around 31% of all global deaths. And under this, 9.48 million people died because of ischemic heart diseases. In India, it is similar to the old statistics. Once again, the cardiovascular diseases are the leading cause of death. There were 1.13 million people died in 2010 because of cardiovascular diseases. And in a study conducted in 2013, identified that the prevalence of acute coronary syndrome was 14% in urban population and 7.4% in rural population. So, whenever the patient admitted in the hospital because of acute coronary syndrome, first time, patient will be prescribed with a number of prerequisite medications, and while discharging, he is going to be prescribed with a good number of medications which are very much required to the patient. Unlike the developed countries, in India, we don't have much about the nursing home facilities and the old age home facilities. So usually the people used to go to the homes, and during this transition, there were a number of medication-related problems and the medication non-adherence we used to see, and that's going to be caused once again the re-hospitalization and compromised health-related quality of life. The studies conducted in Western countries, they identified that the medication reconciliation as well as the proper counseling by the clinical pharmacist can reduce the number of medication-related problems, and that achieves the better clinical outcomes as well as the quality of life. So with this background, we conducted a study to assess the role of clinical pharmacists in post-hospitalization care among the patients with acute coronary syndrome. And I can say that this is the first of its kind study conducted in India to assess this impact of clinical pharmacists in the community setting. In this study, our primary objective was to assess the impact of post-hospitalization care by clinical pharmacists on the number of re-hospitalizations for recurrent acute coronary syndrome. Under this, we have secondary objectives like to assess the same on time to first re-hospitalization for recurrent acute coronary syndrome, medication adherence, health-related quality of life, knowledge on acute coronary syndrome, and number of medication-related problems. We have conducted a prospective randomized single-blind parallel group study. Here the patients were blinded with the intervention given, and we conducted the study in Department of Cardiology, Jesus Hospital, Mysuru, India, for a period of 1 year. And we have included the patients, either gender and above 18 years of age, and diagnosed with acute coronary syndrome defined by American Heart Association, and the patients having a personal telephone number or a mobile number, and who are living in the Mysore city, within the city, and who are willing to provide the informed consent and participate in the study. And we have excluded the patients who are having the dementia and mental illnesses, and patients with the vision and auditory impairments, and patients who can't read the local language, that is Kannada and then English. Patients discharged against the medical advice. So we have excluded these patients because we may not get a proper information, and we may not be able to provide the clinical pharmacy services for these people. So we have recruited all the patients after reviewing the medication charts of the patients who are admitted in the Department of Cardiology, and we enrolled the patients who are comes under the study criteria, eligibility criteria. After enrolling the patients, we have collected their demographic and medical data in a suitable data collection form, and we will document it in the online data collection form. So soon after we recruited, we assessed for knowledge on acute coronary syndrome, because they were first time diagnosed with acute coronary syndrome. We would like to assess what is the knowledge of what is the knowledge they are having on the ACS initially by using the scale that is a heart disease fact questionnaire, which is a 25-item questionnaire where we can have 3 options: true, false, I don't know. And in that we can have one option is a correct answer, and we are going to see how many correct answers multiplied with the 4 we are going to get the percentage. And based on after that we have provided the basic counseling for all the patients as part of clinical counseling services. And then we have randomized the patients into 2 groups, intervention group and the control group, by using a simple block randomization. So in the intervention group, the patients were provided with patient information leaflets as well as discharge medications. Patient information leaflets contains the disease information as well as the information on the medications they are going to be used. And the discharge medication cards we are giving just for identification and improving their medication adherence. So we are going to be code each medication and when to take, how to take. So all these things we have written in a medication card and we have provided to the patients. And after the discharge, we have provided the telephone calls 48 hours, 7th day and 50th day after discharge. And we made the home visits on 30th and 60th days after discharge for both patient counseling as well as medication reconciliation. And during these visits, home visits, we inquired about the primary outcome as well as secondary outcome, and also we assessed health rate and quality of life by using MACNU, quality of life after medication, so after myocardial infarction, and medication adherence by using Morrisky medication adherence scale age, and knowledge on ACS once again by the heart disease fact questionnaire. And also we assessed for the medication related problems suffering with the patients. In the control group, we have done the same, but we didn't go for any home visits. We followed the patients during their hospital visit for the follow-ups at the 30th day and 60th day. So after the discharge, the cardiologist will ask them to come for the follow-up, usually after 15 days, followed by every 15 days. So whenever they come to the hospital, we followed them. And we have made the phone calls, not for the counseling, we have made the phone calls for reminding them about their appointment to the hospital. And also we inquired similarly their quality of life, medication adherence, knowledge, and medication-related problems. So finally, we have analyzed the data for the primary and secondary outcomes. And the statistical analysis, we used descriptive statistics for demographics and clinical characteristics of both the intervention and control groups. And chi-square tests were applied for categorical variables, independent t-test for continuous variables to identify the significance in difference between the groups. And paid t-test was applied to identify the significance improvement in the knowledge as well as health rate and quality of life. And the data analysis was performed by using SPSS version 23. Coming to the results, unless the other presentations, I have the number only in hundreds, not in thousands, because it's the hard copy review and we are taking the patients who are admitted in the hospital. We assessed a total of 384 patients for the eligibility. And under that, there were 326 who comes under exclusion criteria. And the major drawback was the patients who are not residing in the Mysore city. So following those patients may be difficult. So we excluded those patients. And remaining, we had 58 patients were randomized into 2 groups, intervention group and the control group. 26 in the intervention group and 32 in the control group. We followed them up to 6 months, up to 60 days. And during the follow-up, there were 8 discontinued under the intervention group, 12 under the control group. And finally, we had 18 patients in the intervention group and 20 patients in the control group for the primary and secondary outcome analysis. So coming to the demographic details of the patients, we did not identify any significant differences between intervention group and the control group in terms of gender, age, smoking, and knowledge on ACS, acute coronary syndrome, except the alcoholic status, where the percentage was more in case of control group, where they are non-alcoholics. Coming to the primary objective, the number of re-hospitalizations. So there were 2 in each group readmitted because of acute coronary syndrome once again. The only difference we can see is the average duration for the readmission, 96 days in the intervention group and 7 days in the control group. I don't say that it is because of our intervention, it may be one of the reasons because they admitted because of the treatment failure. Secondary objectives, knowledge on acute coronary syndrome. So we have seen in the intervention group as well as in the control group, starting from the discharge as well as day 30 and day 60. So we can see the improvement in the knowledge among the intervention group. The median percentage was 8 in the discharge, and it was improved to 48 and 60, and it was found to be significantly improved from discharge to day 60. As well as in the control group, the median score was 10% while discharged and 36 at day 30 and 56 at day 60, and even here also we can see there was an improvement. So that maybe once again we are following, even though we are not going to their homes, we are following them in the hospital visits. So that may be the reason for improving this knowledge about acute coronary syndrome among the control patients. Coming to the health and quality of life. So once again we have taken the health and quality of life at day 30 and day 60. So in the intervention group, day 30 it was 5.14 and day 60 it was increased to 5.42. And even though it is not significant, we can see there is some improvement in the quality of life of the patients in the intervention group. In the control group, we did not see any improvement, 5.15 to 5.14. So we did not find any significant improvement in the health-related quality of life in the control group. Coming to the medication adherence, the medication adherence was assessed at day 30 and day 60, both in the intervention group as well as control group. The control group was 100% adherent, highly adherent, both at day 30 and day 60. There were some people who comes under the low adherence in the intervention group at day 30, and day 60 they came into the medium adherence as well as the high adherence. These are some of the medication-related problems we identified, and all these problems were identified in the intervention group. Some of them failure to receive the drug, inappropriate drug use, and inappropriate frequency of the drug, and adverse drug reactions. All these things were solved by consulting with the physician, and all these medication-related problems were observed in the intervention group. It is not the meaning that we did not observe anything in the control group, but we could not able to spend enough time when they come to the hospital to identify all these medication-related problems. So finally, I would like to conclude that post-discharge follow-up by clinical pharmacist has been increased the knowledge, health-related quality of life, and the medication adherence among the patients with acute coronary syndrome. And the more of the studies required as by taking the large sample sizes for further strengthening this evidence and implement the clinical pharmacy services in the community setup, especially in India. So more than our results, we were very much satisfied with the feedback given by the patients during their home visits. So thank you very much for the patient listening.
So my name is Katie from Monash University. Thank you for your presentation. That was really interesting. I just wanted to ask, I noticed that there wasn't an even split in numbers in terms of the intervention group and the control group. So I don't know if you could please comment on why that was, given that it's randomised group.
Sorry, can you please repeat it?
Yeah. So on your slide,
Yes.
you had, I think, 58 participants, some sort into intervention and some sort into controls. But I noticed that 58 participants weren't divided evenly. So there was, I think,
28 and how?
Yeah, 28 and 30.
It's not equal now.
Yeah. Can you explain why that wasn't equal, given that?
Exactly, thank you. So it is because of the block randomization, and what we have done is initially just to balance both the intervention and the control group. We have made 10 chips with a numbering, and which was given to the cardiologist. So whenever the patient comes, the cardiologist is going to give that chip, and based on that they are going to decide either the patient will come in the intervention group and the control group. This is an ongoing study, so still we are recruiting the patients. At current, there is an imbalance. Maybe at the end of the study, maybe we can balance both the groups.
Thank you very much for your presentation. Could you tell me please what method do you use for assessment of treatment adherence? And what are main causes which you excluded so many patients?
Yeah, that's the main reason is patients who are not residing in the city of Mysuru where we conducted the study, because we need to go to the homes for follow-up visits. So it will not be practically possible if they are not residing in Mysore city. So that's why we excluded most of the patients.
And better for adherence.
Sorry?
How do you measure medication adherence?
We measure medication adherence by using a scale. There is a Morris medication adherence scale 8. And there we have 8 patients. And whenever all the 8 patients are positive, we can say highly adherent. 6 to 7, we can say it's a medium adherent. Less than 6, we can say it's a low adherence. Yeah.
Can I just ask a quick question? I was interested in the number of people that you lost to follow-up. Could it be that they actually experienced the primary outcome and were admitted to hospital, and so you weren't able to follow them up?
And that's not the reason actually. That's not the reason. So the main problem occurred that whenever we have taken their contact numbers during the hospital admission, when we contact them back, we were not able to reach many patients. So that's what the main problem.
Good morning, everyone. My name is Ting Ma. I'm a PhD student from the UCL School of Pharmacy. Today, I'm presenting the study polypharmacy and risk factors in patients with cardiovascular disease. Our authors could declare that there is no conflict of interest regarding this study. I'd like to introduce the background of the study first. Polypharmacy is generally understood as the concurrent use of multiple medication items by one individual, and it is very common in patients with cardiovascular disease. But the data are limited on patterns and the potential risk factors of cardiovascular polypharmacy. So the study aimed to investigate the patterns of cardiovascular polypharmacy and its associated risk factors in patients with cardiovascular disease. This study was a cross-sectional study. The inclusion criteria included patients aged 45 years old and above, with first diagnosis of coronary heart disease or stroke, and had registered for at least 3 years in SIN database. We excluded patients if died within the first 90 days after the first cardiovascular disease. The data source was the Health Improvement Network database from 2007 to 2016. The SIN database is a primary care database which includes anonymized data from general practices across the UK. It represents about 7% of the UK population. The diagnosis and the clinical information were identified using reading code. The prescriptions were identified by drug codes. The treatment of the study was based on prescriptions issued during the first 90 days after the first cardiovascular disease. Cardiovascular drugs with at least 2 prescriptions were included. We included patients who received at least 1 cardiovascular drug issued during the first 90 days. We defined cardiovascular polypharmacy as a concurrent use of 5 or more cardiovascular medications by one individual. The potential risk factors associated with cardiovascular polypharmacy we examined included age, gender, smoking status, alcohol consumption, BMI, blood pressure, total cholesterol, deprivation status, and Charlson Comorbidity Index. The data presented as mean for continuous variables and as numbers for categorical variables. The multi-variable logistic regression was used to examine the association between cardiovascular polypharmacy and the potential risk factors. The results show that from 2007 to 2016, 104,773 patients with cardiovascular disease were included, and 55 were male. 54,078 were patients with coronary heart disease, and 50,695 patients were stroke patients. The mean age was 69.8 years old. The chart gives the information about, say, a percentage of patients receiving different numbers of cardiovascular drugs concurrently. The green line presents a result of the total cardiovascular disease patients We can see the percentage in patients with 2, 3, 4, and 5 cardiovascular drugs concurrently were similar, or around 18%. But when we examine the drug utilization separately between the patients with coronary heart disease and stroke, we can find they have the difference. In coronary heart disease patients, we can see the majority of patients received more than 4 cardiovascular drugs concurrently. But in stroke patients, they mainly received 2 or 3 cardiovascular drugs. On average, coronary heart disease patients received about 1.5 cardiovascular drug more than stroke patients. In terms of the usage of particular cardiovascular drugs, we can say the aspirin, collectible, Rampro, simvastatin, and atorvastatin were commonly used in the 2 diseases of patients. But from the result, we can tell that there are some difference between the 2 diseases. When examining the classification of cardiovascular drugs, antiplatelet drugs, lipid-regulating drugs, and renin-angiotensin system drugs were all frequently prescribed in the 2 groups of patients. The differences between the 2 diseases were that beta blocker and anti-angina drugs were commonly issued in coronary heart disease patients. Diuretics and calcium channel blockers were commonly issued in stroke patients. The drugs with red highlights presents the top 5 classes of cardiovascular drugs issued in the 2 diseases of patients. So based on the previous results, we also investigated the combinations of top 5 classes of cardiovascular drugs. We can say in coronary heart disease patients, the majority received the combinations of 3 and 4 classes, and the total percent of the 2 groups exceeds around 60%. This is a list of the most commonly prescribed combinations of classes of cardiovascular drugs in CHD patients. The combination of antiplatelet drugs, lipid-regulating drugs, beta blocker, and then ACEI or ARB was commonly issued in CHD patients, as well as a combination of the whole 5 classes. In stroke patients, the majority received a combination of 2 or 3 classes of antiplatelet drugs, lipid-regulating drugs, and ACEI or ARB, CCB, and diuretics. The combination of antiplatelet drugs and lipid-regulating drugs with an additional ACEI or ARB were commonly prescribed in stroke patients. Lastly, we examined the risk factors associated with cardiovascular polypharmacy in the total cardiovascular disease patients. From the results, female patients were less likely to receive 5 or more combination therapy, and the possibility of receiving cardiovascular polypharmacy decreased with age. Former smokers, overweight and obesity patients were more likely to receive cardiovascular polypharmacy. And cardiovascular polypharmacy was also associated with a higher Charlson comorbidity index and a higher deprivation status. Alcohol consumption, blood pressure status, and total cholesterol status show no significant association with cardiovascular polypharmacy. Our study has some strengths. Firstly, the study used a large representative population sample through the same database. The study compared the drug utilization between the patients with coronary heart disease and stroke, and it provided detailed information about the patterns of cardiovascular polypharmacy. There are some limitations as well. Firstly, the study cannot tell if drugs were actually taken or properly used by patients. Secondly, because the SIN database is a primary care database, so we cannot examine the information of the over-the-counter drugs. The conclusion is that polypharmacy is commonly used in patients with cardiovascular disease in the UK primary care. The main risk factors associated with cardiovascular polypharmacy are gender, age, smoking status, BMI, multimorbidity, and deprivation status. Thank you.
Thanks for the presentation. My name is Nick. I'm a student at the University of Rhode Island in the United States. So I had a couple of questions. The first one is, how did you differentiate concomitant medication use and people who switch medications throughout the
Oh, okay. Because this study just focused on the initial treatment of the cardiovascular disease, so we did not examine the switching use.
And then my second question was, your definition for polypharmacy changed for those people who have more severe disease, such as uncontrolled hypertension. Sometimes those patients need 1, 2, 3, 4, 5 agents to control their hypertension, but it's not necessarily a bad thing as long as their disease is under control.
Do you mean the patients with hypertension? They are more likely to have more drugs?
Yeah, as an example, sure. Like, someone with uncontrolled hypertension would need several more agents to get their blood pressure under control.
Yes, from the result we can see there, from the result in my study, there is no significant association with cardiovascular polypharmacy in patients with hypertension. Actually, in clinical practice, we know that if a patient has hypertension, they have to have cardiovascular drugs to control their blood pressure. So actually, in this study, in the normal growth, maybe some patients, they have the normal blood pressure because they have received blood pressure drugs. So actually, this study did not tell if the normal patients with normal blood pressure patients are actually didn't have hypertension. But it's true, patients with higher blood pressure, they will have more cardiovascular drugs. So in my following study, I will do a further study about if patients have previous cardiovascular drugs or not, if they have reality they have hypertension or not, and compare the results.
We have another question.
Okay, thank you for the presentation. My name is Tugaku from Shanghai University here in China. I would like to know that from your characteristics of the study samples, you included like more number of males than females. So, do you mind that it may have effects on the as a risk factor for the gender difference? Because it shows females are less likely to have such kind of risks than males by training 8%.
Okay, did you mean that they... Sorry, can you repeat your question? Sorry?
I mean the number of males in your sample a little bit more than females, so it might have, I mind that it might have effect on your results that there is a gender difference. In the females, the number of females is 45 compared to males, that's 55. So in the results, the females are less likely to have risk.
Okay, I understand. I think the difference between the number of the two groups of patients is not very large. And I don't think it will affect the result of the result. Yeah. So, but I will check. Yeah. Thank you.
We have time for one more question. May I ask for a point of clarification? I may have missed it, but I'm interested in the time that it took from the diagnosis forward to define your polypharmacy pharmacy? I may have missed.
Yes. The 90 days?
It was 90 days plus the diagnosis.
Yes. In this study, we included the prescriptions issued during the 90 days.
Okay, so you only looked at the first 90 days and
Yes.
what prescriptions. So I guess that taps into the point that Nick made that, not 3 months is quite a long time, and so there may well have been some switching potentially within that period. Is that true or?
Yes, actually, because this database is a primary care database, and there is a problem that if a patient has a cardiovascular disease, they have to go to the hospital first, then they will go to the GP. So there will be a gap between for the GP to input the data into the system. So we have to give them a period to ensure we have the enough or the true information about the drug utilization. So that's why we have a 90 days duration.
Okay, good morning everyone. My name is Han-Wen and I just got my master's degree of public health from Australian National University. And today I will share the topic of the trends in adverse drug reactions-related hospitalizations over 13 years in New South Wales, Australia. So today's presentation will be divided into 5 parts, and the first part is the introduction. So what is the ADRs? ADR is actually the abbreviation of adverse drug reactions, and ADRs are injurious consequences resulting from medications in proper therapeutic use. And here, ADR refers to the causal connection between proper use of medications to adverse events, excluding those due to medication errors. And why we care about the ADRs? Previous studies showed that although the incidence of ADRs in Spain decreased over the time, the ADR-related admissions in the US, the UK, and Portugal increases over time. And in Australia, we found that the incidence rate of ADRs in Western Australia increased among patients over 60 years old. However, there is lack of data on the recent trends of ADR-related hospitalization in Australia. And how ADR-related hospitalizations change over time is not clear. So our aim of the study is to examine the trends in ADR-related hospitalizations in New South Wales, which is the most popular state in Australia, and we think the findings may have implications for ADR countermeasures to reduce the associated health care burdens. So here's the methodology of the project. So for the data sources, we used New South Wales admitted patient data collection during the period of the July 2001 to June 2014. And actually the New South Wales APDC is a complete census of hospital separations in New South Wales, and it is maintained by New South Wales Health Department. For the medical reasons of hospital admissions, we used Australian modification of ICD-10 version. And here are the definitions in our project. So we selected ADR-related hospitalization using the Australian modification ICD-10 version from the Chapter 20 External Causes of Morbidity and Mortality. Subjects with unknown age and sex were excluded, and we categorized the age into 5 groups and sex as male and female. We also used Charlson Comorbidity Index to classify the severity of comorbidities as minor, moderate, and severe. So Also, we use separation mode to identify the cases that died at hospitals, had been discharged to home, or had been transferred. Medications are categorized into 20 groups according to the ICD-10 categories. And we also categorize the primary diagnosis as the clinical condition according to Australian notification ICD-10. So as for the statistical analysis, we calculated the annual incidence rate. But considering the population age structure may change over time, we also calculated directly age standardized rates. And annual percentage change, which is APC, was used to evaluate trends of age-adjusted rates over time for ADR-related hospitalizations. The softwares used for the statistical analysis were joint port regression program and Stata. Now here are the results of our project. And we can see that during the study period, there were 315,000 ADR-related hospitalizations. This is the total number, and I think there's something wrong with my PowerPoint. So for the female, the number accounted for 45%, and for the male, it's accounted for the 55%. You can see there is a little bit difference between them. And for the age, the people with the age between 65 to 84 accounted for about 61% of the whole episodes. And here is the trends of the ADR-related hospitalizations. And during the study period, we can see that the APC was 5.8%, and the age-adjusted rate increased from the 220 to 430 per 100,000 people. That's a huge number, actually. And here is the details of the ADR-related hospitalizations with different patients with different characteristics. So about the medication therapeutic groups, there were 97% of the ADR hospitalizations were coded with indication of medication causes, and the trend of the ADR-related hospitalizations caused by medication is, you can see that the APC was 6%, and the age-adjusted rate increased from 210 to 420 per 100,000 people. And when we see this picture shows the leading medications contributing to ADR-related hospitalization. And we can see that the leading medication caused the ADR hospitalization did not vary extensively. And we can see that anticoagulants were consistently the most common medication that caused ADR-related hospitalization, followed by the opiates and related analgesics and antineoplastic antibiotics. So this picture shows the trend of all the medication groups related to the ADR hospitalization, and we can see that it's a little small. So we can see that there are two kinds of medication groups we need to notice. The first one is the agents affecting blood constituents, as it has the greatest increase with the APC of almost 11%, and the agents affecting cardiovascular system has the smallest increase with the APC of 3.2%, but the age-adjusted rate of the agents of cardiovascular system was always the highest. So these are the examples of the trends we just got from the results of the trends of the ADR-related hospitalizations caused by these three kinds of medications. So when we say the primary diagnosis group, we can see that the predominant conditions that warranted ADR-related hospitalizations are blood disorders, nausea and vomiting, and heart failure. And we can see that the number of the blood disorder accounted for 2.7%. So this is the trend of the primary diagnosis group with the ADR-related hospitalization. And we can see there are four kinds of the main primary diagnosis group related to ADR hospitalization. And they are the infections, and the mental disorders, and the musculoskeletal disorders, and poisoning. Sorry. So let's go to the discussion part. So there were 3 points we got from the results that we need to discuss about. The first one is older people have elevated risk of ADR-related hospitalizations, and the potential reasons of this point is that they may experience aging-related physiological changes, which may affect the medication process in vivo, and they may use more medications and use medications more incorrectly. The second point is the sex difference exists in hospitalization ADR. It has been discussed in many studies that sex has differences in ADR-related hospitalizations, but it remains unclear. And we think the further consideration of countermeasures should consider sex difference in both reaction to medications and patterns of use. The third one is really important. We see that there are 3 kinds of medications identified as causes of ADR hospitalizations, and they were the drugs to treat cardio diseases and the opioids-related analgesics. And we inferred that the CVDs are primary causes of deaths and disabilities in Australia. So Australians may use more medications to treat their cardiovascular diseases, and that's why there are many ADR-related hospitalizations. And the opioid-related analgesics, we infer that it is because with the increasing of the chronic pain, there are more people using the opioid-related analgesics, so there are more ADR-related hospitalizations. And the conclusion is that although our study demonstrated significant increases in ADR-related, its attribution is still complex. And in future, we need to study more on the increasing trends of the ADRs. So this article was accepted by Internal Medicine Journal. If you are interested in the details of this paper, this project, you can find it on our website. And I would like to thank the following individuals and organizations. Wei-Du is my supervisor, and the study was supported by National Health and Medical Research Council, Center of Research Excellence in Medicine and Aging. Thank you.
Okay, thank you for your nice presentation. I want to know that your database is from one of the hospitals in New South Wales, and I would know, can we take as a generalization to Australia as a whole, because the findings can present only the data was from New South Wales. So can we generalize to Australians your result?
I don't actually. New South Wales is the most popular state in Australia, so I think it can be said it is representative. But I think there is something specific in other places in Australia. So I don't know, but we may take more researchers in other states of Australia.
Just to clarify, it's not just from one hospital in New South Wales, it's all hospitals in New South Wales. Okay. The collection of those 200 plus hospitals in New South Wales. Okay. Pardon me?
It's New South Wales, right?
Yes, the most popular state in Australia. So there's other research that's been shown that the findings of New South Wales often apply to the rest of the country.
Good morning, everyone. Today my presentation will be introduced about the characteristics of post-marketing observational study in China. Data will be from 2013 until 2018. Before I start my presentation, I want to declare that I'm the full-time employee of Korea. I've been involved in the study, including study design, data analysis, and reporting writing. However, my presentation will be not involved in any conflicts of interest. Yeah. My presentation will be in this floor. I will introduce that from background back to 2012. There is a pilot issued by China Regulatory Agency. They required to set up one registry platform. At that time, they called Registry and Publicity Platform of Drug Clinical Trial in China. The purpose is to require all the clinical trials in China to register their information about the clinical trial, to make the information be public available and to improve the transparency. In 2013, there is an order, we called Order 28, was issued to require that all the clinical trial, including PK, PD, the clinical trial from phase 1 until phase 4 should be registered in this platform. If the clinical trial meets the following requirements, for example, if they apply for one approved letter in China, or they will be the industry will conduct clinical trial in China, all the information about the clinical trial should be registered in this platform. Here I listed the platform website and also listed the order 28. As I just mentioned that based on the order 28, all the clinical trial should be registered in this platform set up by Center of Drug Evaluation. The objective of our analysis is to try to characterize the post-marketing observational studies registered in this platform from January 2013 until June 2018. And the reason is background that more and more real-world evidence clinical trial, including post-marketing observational study, has been required by China Regulatory Agency, but we don't know how many and how details the information could be available to the public. The methods we used is to research using the following terms, including observational study, non-observational study, post-marketing, real-world, or epidemiology. If we identify the records or duplicated, we will only keep one record in our database. We use the descriptive analysis to understand the characteristics of observational study in this platform. This slide shows that how many studies have been registered in the platform and how many post-marketing observational studies were identified. Unfortunately, there are lots of studies have been registered in this platform, but only 15 post-marketing observational studies were identified after excluding the duplicated records. For example, women searched the studies using observational. We only identified 11 studies using observational study term and 3 studies using non-observational study, and 40 for post-marketing study, 11 for real world, and 5 for epidemiology. We removed 20 duplicated records, and finally, there 40 records were analyzed. These two graphs show that how many patients were registered in this platform by year. You can say in 2011, there are 14 studies. That's the maximum number of post-marketing observational studies registered in the platform. However, based on our understanding, we think there should be more observational studies has been required by China Regulatory Agency, but maybe they are missed from this platform. The status, most of the studies were ongoing. They are only 2% have been completed. When we look into the therapeutic area, we can see the top three therapeutic areas are oncology, respiratory, cardiovascular disease, and vaccine. Another information we would like to share is that what kind of information has been available from this platform. There are limited information available to the public based on our searching work. For example, the following information is not available, including study objective, including excluding criteria for the study population, the sample size, and follow-up period, comparators, and the results. They are not available. However, I think some of you may be familiar with the FDA database and the PASS database in EU. So I think the information is very limited available to the public. The available information in the platform is only limited to the registered number, drug name, indication, and study title. In our analysis, actually only based on the limited information and to determine the study design. The study design we identified from the study title. We found that all 50 studies were prospective study design with primary data collection. The endpoint mentioned in the study title, including effectiveness, safety, both, or either of them were mentioned. Among the 50 studies, only 2 mentioned effectiveness in their study title, and 7 mentioned safety only. In 14 studies mentioned both effectiveness and safety in their study title. There are 27. We cannot identify either effectiveness or safety were mentioned. However, they mentioned that observational study or post-marketing or prevalence, or they immediately specify about either their study endpoint in the study title. You can see we shared very limited information. The reason is that the information registered in the platform is very limited. Actually, China Regulatory Agency required more information than we presented today. However, there is an option in the database that the industry could choose either make this information public available or not. Our conclusion that there are only very low proportion of post-marketing observational study registered in the platform has public available information. All the information we searched were prospective study design with primary data collection. Based on our experience in EU and in the United States, we still recommend that China Regulatory Agency to consider that record more information for the registered study and make more information available to the public. This will help publicity and also the industry and the patients to be know better about the study to help to improve their health status. Yeah, thank you. This is a very short and presentation to introduce here. Here's my contact information. If you have any questions, I would be happy to answer. And I will also take this opportunity to thank Dr. John Legend, who is my mentor when I prepare for this abstract and presentation. Thank you.
Hello, Alison Berg from IQVIA. Thank you very much for a lovely presentation. I have two questions, and you may have said it and I missed it, but number one is it mandatory to register studies in the platform? And the second question is, do you think that we might have missed some of the studies because it wasn't in the title, or is it just that they weren't there?
Yeah, thank you for your question. It's a very good question. Sorry, I didn't forget to mention the first question is for if the registry is mandatory or not. Actually, the China Regulatory Agency required all clinical trials, including observational study, should be registered in this platform. So the conclusion is that it's mandatory. However, based on our data analysis, we don't think that all the information should be registered in the platform. That's why we recommend that make more information public available. Yeah, thank you. Could you repeat your second question? I didn't get your point. Thank you.
Because you had to rely on the title to see if it was observational, do you think that there are more observational studies in there, but it's not obvious from the title, or are they just not registered?
Yes, I think more. I think not only the primary data collection study data should be registered, actually other studies including database analysis and like medical chart review should be also registered if they are required, like they are monitored either post-marketing requirement or post-marketing community study. Another point I want to add is that this database is actually in Chinese. It's very hard for industry to use. If there is an English word available, or if there is a database specification could be available, that will be helpful for us to make further analysis in future. Thank you.
Hello, my name is Young from GSK Vaccine. So my question is basically in IQVIA, have you done similar study in Europe and also in the US? Have you used the similar methodology for the abstracting of the studies?
Yes, thank you for your question. The methodology is the same. However, the information is different because in EU, for example, in United States, FDA actually have a database. The database including the information not limited for the information I just presented, but also including primary endpoint, and if the study report has been submitted, if the study is pending, why. So you can make very comprehensive and detailed data analysis. Actually, we have, by our Dr. John Legend, my mentor, actually has analyzed one database for its
It's called Post-Marketing Requirement Database for Medical Device in the United States. We have this. If I recall correctly, this results have been published in some journal. And in EU, there is a website they call ESEP Register, and all the post-authorization safety study should be registered in that website. And for some studies, the report should be made available to the public, even the protocol, I believe. So, yeah.
Yes, to add to that, I agree. NSEP, and in addition, IQVIA has done the analysis on post-marketing studies, observational studies in Europe, so it's the same in the US.
Yeah, thank you.